Hey everyone, and welcome to this presentation on the diagnostic criteria for eating disorders and the DSM-5-TR. In this video, we're going to review the diagnostic criteria, differential diagnoses, comorbidities, and risk factors for avoidant restrictive food intake disorder, anorexia, bulimia, binge eating disorder, and although it's not actually in a diagnosis in the DSM-5-TR, we are going to talk about food addiction too. So, normally I start out with the diagnostic criteria, but I think it's really important that we note the prevalence of these disorders in the world as well as in the United States. The 12-month estimates, that means during any 12-month period of time, if we're looking at prevalence, the estimates for anorexia range from 0.05% to 0.3%. Now, remember, this is not a lifetime prevalence, this is in any 12-month period. 0.05 to 0.3% of people are meeting diagnostic criteria for anorexia. Bulimia is 0.14% and all the way up to 6.7%. So there's a wide amount of variation, and binge eating disorder is 0.44% and to 1.2% or 3% in US adolescents. Now, it is important to note that the prevalence tends to be somewhat higher in the US than in other countries. So what you're looking at the prevalence data, if it seems to be exceptionally low compared to what you're seeing in your communities or in clinical practice, it's important to recognize that the impact that might occur in the studies when we're looking at it worldwide and not just at North America, for example. Eating disorders are currently the deadliest mental disorder in the United States, affecting an estimated 12 to 25% of all college-age women. Okay, that was not my statement. The deadliest mental disorder, that came from this peer-reviewed article. So it's important to recognize that, no joke, just because, quote unquote, just because it's food as opposed to something else doesn't mean it's any less detrimental. As a matter of fact, it's more detrimental in some ways, and the mortality is not just due to suicide. The mortality is due to a variety of conditions that we'll talk about. Unfortunately, the incidence of anorexia among younger people under age 15 has increased over the past decade, which is really disheartening. I was hoping that the movement towards body positivity, that we would see a movement away from eating disorders. Instead, it seems like we're just going the other direction. Mortality for people with anorexia or bulimia is 500% or 5 times greater than controls. So let that just sink in for a second. So mortality rate is huge. The prevalence of disordered eating varies from 0 to 19% in male athletes and 6 to 45% in female athletes. This is another one of those subsets that we're looking at. So if you work with athletes, and I don't just mean people, only people who are in college or on a college sports team. We want to find athletes, or we want to define this sort of broadly and recognize that it's a lot of girls and boys become athletes in middle school and high school, and obviously in college, and continue to be very athletic and considered to be athletes beyond college. So we don't want to ignore the early onset of eating disorders in younger populations, and even thinking about some of those sports that have a pretty extreme focus on body weight and shape: ballet, gymnastics, wrestling, football. I've even seen it in swimming. Culturally, anorexia appears to be more common in non-Hispanic, white, biologically female people in the United States. Bulimia nervosa appears to be similar across US ethno-racial groups, so that was kind of interesting. There was no information about the impact or the prevalence of eating disorders in the transgender population, so I'd be interested to explore what that looks like, but for now, we just really don't have a lot of data. So let's start out with avoidant or restrictive food intake disorder. This is not anorexia. Avoidant restrictive food intake disorder, the person shows a lack of interest in eating food or a lack of interest in food altogether. They may show avoidance based on sensory characteristics of food or concerns about aversive consequences of eating. Now, those aversive consequences are not change in body shape or weight gain. That would be anorexia. The aversive consequences here will be described in a minute. But because of their lack of interest in food or avoidance of food, the person experiences significant weight loss or failure to achieve or maintain an expected weight. And that's between the person and their physician, whatever that expected weight might be. and significant nutritional deficiency, dependence on enteral feeding, like a feeding tube or oral nutritional supplements, marked interference with psychosocial functioning. And now they only need to have one of these symptoms. Therefore, avoidant restrictive in food intake disorder is relatively easy to diagnose in people who have significant weight loss, failure to maintain expected weight, or a nutritional deficiency. The disturbance is not better explained by a lack of available food or by an associated culturally sanctioned practice. And what they mean here, for example, periodic fasting, you're not going to see the significant weight loss as a result of fasting for a day or even going on a limited ingredient diet that would be culturally prescribed or religiously prescribed. So maybe something like Ramadan in the Muslim culture that's happening right here, right now for us, where there's this obligatory fast every day from dawn to sunset. And I believe that even includes drinking water. So that's an example of something that would not meet this criteria as it would be considered culturally appropriate. And there is no evidence of a disturbance in the way in which body weight or shape is experienced. With this particular disorder, the person is avoiding food based on its characteristics. They don't like the smell, the taste, the touch, or really, we see a lot of texture issues here, or aversive consequences. And those aversive consequences could be due to like gagging or swallowing. There's a lot of different things that might happen. The eating disturbance is not attributable to the concurrent or to a concurrent medical condition, including pregnancy. So, in pregnancy, a person may experience food aversions, so like morning sickness. However, it does not significantly impact weight. And if it does impact weight, maybe this is just better diagnosed or better explained in terms of pregnancy and not a restrictive food intake disorder. Food avoidance or restriction is due to sensory characteristics or qualities of food, or as a result of a conditioned negative response associated with food or a particular food, such as making somebody choke or repeated vomiting, or even a traumatic procedure like when they might stick a scope down your throat and the person gags. So we do want to do an effective intake process when we're asking a person about this. What triggered the onset? Was there a procedure being done? Was there something that triggered that onset? Or is there a particular food? Is it all foods? Which ones are you avoiding if you're not avoiding all of them? So some people have a sensory response to particular foods where with a particular texture, it's hard for them to swallow, but it doesn't have significant consequences. It doesn't lead to significant weight loss. And, it's likely just with that one particular food. Think about maybe some of those sensory issues in autism that we discussed. Maybe mashed potatoes just aren't their jam, but it's not going to impact their weight or development much if they never eat a mashed potato in their life. Now, when all foods come with a sensory issue, we really want to look at this. A referral to ear, nose, and throat doctor, or maybe a referral to an occupational therapist might also be helpful, especially in children. It's more of a medical condition. You should recommend that they talk to a doctor about that. Avoidant restrictive food intake disorder is more common in children and adolescents, and triggers include a variety of things from physical sensations to social situations and even emotional difficulties. They may have associated eating with emotional distress, and now whenever they're presented with food or an opportunity to eat, their body triggers a stress response and their stomach gets upset. And moving on to anorexia, restriction of energy intake relative to requirements leading to significantly low body weight in the context of age, sex, development trajectory, and physical health. And we're going to talk about, I keep saying maintaining an expected weight. We're going to talk about that in a minute. But in anorexia, the person is willfully, intentionally restricting their food intake as a means to lose weight or control their body shape. They must have an intense fear of gaining weight despite being at a significantly low weight, and a disturbance in the way in which their body weight or shape is experienced. Undue influence of body weight or shape on self-evaluation, or persistent lack of recognition of the seriousness of the current low body weight. So let's look at that. A disturbance in the way in which one's body shape or weight is experienced, some people with eating disorders will perceive their body as being much larger than it really is. People with eating disorders tend to overestimate their size and shape by about 20 to 40%. So that's pretty significant. They think they look a lot bigger than they actually are. So, people with eating disorders, and in particular, we're talking right now about anorexia, you may see one thing, but they may see something completely different. There may be an undue influence of body weight or shape on self evaluation. That one's pretty self explanatory. Or a persistent lack of recognition of the seriousness of the current low body weight. A lot of people, not all, but a lot of people with anorexia do recognize the seriousness of their low body weight. However, it's less of a concern. They're less fearful of the potential physiological consequences than they are fearful of the consequences of being what they perceive to be fat or overweight. So you have two very intimidating, terrifying things that the person's trying to balance in their own head. And there's types of anorexia. You've got the restricting type and the binge purge type. The restricting type, during the last 3 months, weight loss is accomplished primarily through dieting, fasting, and or excessive exercise. Now, it does get a little confusing in this chapter because under bulimia, they include excessive exercise as a purging behavior. In anorexia, they don't. So where you stick excessive exercise is kind of up to you. If the person is exhibiting other compensatory purging behaviors, then you would probably just put excessive exercise under that. But if their only compensatory behavior is excessive exercise, then it may go under the restricting type. Ultimately, from a diagnostic standpoint, it doesn't make a whole lot of a difference, but from a treatment standpoint, it obviously does because you're going to wrap that treatment plan around these symptoms and about, what is that behavior doing for this person. However, whether we call it restricting type or purging type, we need to look at the behaviors that this person is experiencing or that the person is doing and not get too caught up in this title or label of any type. If they're using compensatory behaviors, let's look at each one of those and try to figure out how to help them to reduce the frequency of unhealthy behaviors and alter those behaviors. Severity for anorexia is based for adults on current body mass index, or BMI, you might see. So, body mass index is a very clunky numerical representation. It's just a math equation of height to weight. So, you can have somebody who's short and very muscular who weighs a lot and will have a really high body mass index, but maybe a body fat index of 1% or less. And that's still potentially an unhealthy situation. So, I personally take issue with using body mass index as a diagnostic indicator. Now, you will notice that I did not include the severity levels here. Why didn't I do that? Many people with eating disorders will see numerical representations and see the numbers as a challenge, like, well, I can get thinner than that, or I can do this more, or whatever, as a way to minimize or excuse or justify, where they're saying, well, according to this BMI right now, I must be fine, when in reality, they maybe aren't. And there's a lot more to the diagnosis of anorexia, bulimia, binge eating disorder than just body mass index. So we do need to be really, really careful. It bothers me when I see stories about celebrities and influencers who have eating disorders and they're talking about the lowest weight that they ever got to. For many people with eating disorders, that's often seen as a challenge. Oh, I can do better than that, or I can get thinner than that. And this is obviously very unhealthy. So we do need to be very cognizant as leaders and as people who are trying to promote mental health, as clinicians, about how and what we say and how we phrase things and how that might be interpreted. The DSM does say that it's not possible to provide a definitive standard for judging whether a child or adolescent's weight is significantly low. Variations in developmental trajectories among youth limit the utility of simple numeric guidelines. So, at least the DSM 5 TR is acknowledging for children and adolescents, we can't really judge with BMI or numbers. And if you think back to when you were an adolescent or when your child was an adolescent, if they go through these growth spurts and it seems like literally overnight or all of a sudden they shoot up 2 or 3 inches, that can greatly alter their body mass index. However, it doesn't necessarily mean that they've developed an eating disorder overnight. We need to look at what's going on and, did they go through a growth spurt or is there something else happening? Diagnosis of eating disorders must be done concurrently with a physician. In most cases, it really is ethical to make sure that we rule out any underlying physiological sensory integration issues that may be contributing to the problem. Bulimia. The person experiences recurrent episodes of binge eating characterized by both eating in a discrete period of time, such as 2 hours, an amount of food that is definitely larger than what most people would eat in a similar period of time under similar circumstances. So, if you're participating in a hot dog eating contest, then what a similar person is going to eat in a similar period of time in that same circumstance is going to be about the same, or hopefully for you less, because we want you to win. But if you're eating that many hot dogs or anything on any given day outside of those circumstances, that's a lot more compared to what the average person is eating. So binging needs to be context specific. Is this person eating more than what most people would eat? And not or, and there is a lack of control over the eating during that episode. And that's one of the key features of binge eating. When people overeat because they love food and there's no sense of lack of control over eating, they just decide very pragmatically, I want to have a third piece of chocolate cake because it tastes so good. A person who is binging may feel like they're not able to resist it. They don't have control. Maybe they're not keeping count. So it's also important to notice that in binges, people with eating disorders have been found to display elevated dissociation as well as greater avoidance of affect, worse distress tolerance, and reduced emotional clarity and awareness. And all of these can be treatment targets. Maybe throwing some mindfulness in there can really help ground and center a person when they're eating. And when you're working with people who binge eat, whatever diagnosis you're going to associate with that, you know, sometimes they'll say something like, yeah, I remember I started eating and then before I knew it, I had eaten the whole bag. Or, I ate until I was painfully full. And they don't really remember the period of eating. They just kind of zone out during that period of time, almost like a blackout when we talk about substance abuse. So, whether you want to diagnose that as dissociation or you want to identify it otherwise, it's really important to note that sometimes it's not a sense of lack of control, like they're sitting there saying, I'm not going to eat that piece of cake, and then they feel compelled to. It may also be during those periods of time that they start eating. And as soon as they start eating, they kind of become, or they dissociate and they check back in after the period of binge eating is over. In bulimia, there's recurrent inappropriate compensatory behaviors in order to prevent weight gain, which can include vomiting, misuse of medications, and there's a variety of them out there like laxatives or water pills. And I'm even curious now about how all these celebrities are using that Ozempic injectable medication for weight loss. If there's binge eating plus Ozempic, that might fall into a bulimia category. Fasting or excessive exercise. Here's excessive exercise as being considered a compensatory behavior. In binge eating and inappropriate compensatory behaviors both occur on average at least one time a week for 3 months. Okay, I want you to stop and think. Remember when we were talking about the prevalence, and some had the prevalence at less than 1%, and some had the prevalence for bulimia at up to 6%. But I want you to think about how many people you know or have encountered or worked with, or maybe it's you, they binge ate at least one time a week for at least 3 months. And remember, that just means eating more than the average person would in that context, and a sense of loss of control or dissociation during that binge eating period. And I would guess that that number is higher than what we're actually getting. But those numbers are hard to track when maybe, we need to think about, that clinically significant distress phrase that the DSM loves to apply here. How often does binging once a week start to create clinically significant distress in someone's life? Maybe less than a severe or extreme severity. So maybe it goes underreported. Self-evaluation is unduly influenced by body shape and weight, and that's a crucial point. And the disturbance does not occur exclusively during episodes of anorexia nervosa. People with anorexia are going to adamantly and vehemently refuse or avoid maintaining what is considered, quote, healthy weight for their age, size, build, etc. So it's important to recognize that there is that difference. A lot of people with anorexia may do what they consider binging, but they're still eating far less than what the typical person would in a similar situation. But they might feel like it's overeating and they may engage in compensatory mechanisms. So, what we're looking at with anorexia is a significant restriction of energy intake. People with bulimia, their weight tends to be closer to normal or even above normal in some cases. However, they have self evaluation that's unduly influenced by body shape and weight. With bulimia, I'll tell you that the levels here, there's an average of 1 to 3 episodes of inappropriate compensatory behaviors per week. So, interestingly, with bulimia, they don't talk about the binges, they talk about the compensatory episodes being at least once a week for 3 months. But when they start to talk about the degree, it's an average of 1 to 3 episodes of inappropriate compensatory behavior. So they're not focusing on the binge. 1 to 3 times per week for mild, moderate is 4 to 7, severe 8 to 13. So we're really getting up there. And extreme is 14 or more. Now, this could be twice a day. It could be multiple episodes in one day. It might be 14 all in one day within the span of a week. We might find that people with bulimia, a lot of times, often they start in the binge purge cycle and there may be multiple cycles back to back. They binge and they feel horrible. They feel guilty. They feel uncomfortable. So they purge and they feel horrible and uncomfortable and depressed and guilty after that, which leads to another binge, which leads to another purge. And we might see that repetitive cycle in bulimia. So you might have 4, 5, 6 episodes in a single day. So, bulimia, compensatory behaviors we're focusing on. The next disorder is the binge eating disorder. And this is recurrent episodes of binge eating, which is characterized by both eating in a discrete period, such as 2 hours or more than a typical person would under similar circumstances, and a lack of control over eating during that episode. So, this is the same as for bulimia. However, there is no compensatory behaviors here. The binge eating episodes are associated with 3 or more of the following, and I don't know why this isn't under binge eating criteria for bulimia. You got me. I didn't write the book. But during binge eating disorder, during the eating episode, the person is eating more rapidly than normal for them, and that's important to consider. So, for example, I'm a pretty slow eater. I like to talk a lot when I'm eating meals. With somebody. I grew up Italian, and I'm sure that that's part of it. I'm talking with my hands, I'm waving my fork around. The conversation is more important than the food that's in front of me, but the food's pretty important too. My husband, on the other hand, is a rapid eater. And by the time I generally take my first bite, because I'm just talking up a storm, his food is gone. And he didn't grow up the same way I did. In his house growing up, when dinner was on the table, everyone was silently eating. Like, going to his house for holidays is a little odd for me. So, what might feel a little rapid for me might be a very normal pace for my husband. So we want to go back to, they're eating more rapidly than normal for themselves. And that is going to be very specific based on that individual that you work with. Eating until uncomfortably full, eating large amounts of food when not feeling physically hungry, eating alone because feeling embarrassed by how much one is eating, feeling disgusted with oneself, depressed, or very guilty afterwards. These are all very common experiences of people after binge eating, whether they have a binge eating disorder or bulimia, or even, we're going to talk about in a minute, food addiction. We do want to rule out some other things that might precipitate binge eating, for example, or at least we want to look at these as treatment targets. Eating more rapidly than usual. Is there a reason for this? Maybe they grew up in a family where they had 10 siblings, and if they wanted to get enough to eat, they really needed to eat rapidly because that was the only way that they could possibly get seconds. Or maybe other reasons they learned to eat rapidly. For example, their caregivers had them overbooked. So they were wolfing down hamburgers or something in the car in the ride between school and their first practice of the day. There are a lot of reasons people may develop really bad eating habits. So we don't want to take one particular symptom out of context. We want to look at that full picture. In binge eating disorder, there's marked distress regarding the binge eating. The binge eating occurs on average at least once a week for 3 months. So this is the same criteria as bulimia, but again, there's no compensatory behavior. And the binge eating does not occur exclusively during the course of bulimia or anorexia. Remember that in anorexia, generally, the amount that the person eats is still very small, even what they would consider a binge, is still going to be significantly under what an average person might eat in that period of time. Now, they may eat until they're uncomfortably full. One of the things that we need to recognize is that our stomach is really only about the size of your fist when you're, balling up your hands and making a fist, and it stretches and it contracts. So when it has food in it, it stretches. When it doesn't have food in it, it contracts. And if you've ever had like the flu, for example, or something, some illness where maybe you didn't eat very much for a week or two, and then you started to eat again, it might feel like you got full so much faster because your stomach contracted down to sort of that fist size. So, it really can only hold an apple at a time, but we stretch it out if we eat a whole lot. So, whatever. For somebody with anorexia, they may be experiencing the same thing if they're not regularly keeping their belly distended with hyperhydration, for example. The severity of binge eating is based on the binges. So remember, the severity for bulimia was based on the compensatory behaviors. The severity for binge eating is based on the binges. So mild is 1 to 3, moderate 4 to 7, severe 8 to 13, and extreme 14 or more. So it's the same breakdown or numbers in terms of severity, but the focus on is on a different behavior here. And other specified disorders, and there are a couple of other specified disorders, but the ones that I think are really important to note because they're more common in clinical practice is atypical anorexia nervosa. In this diagnosis, all of the criteria for anorexia are met except that despite significant weight loss, the individual's weight is within or above the normal range. So somebody may have been way overweight and then they lost a bunch of weight, but they're still, if you're going by the BMI, which, I hate, but if they're still within that normal weight range, or they've gained a whole bunch of weight, or have been morbidly obese, as the BMI level says, lost a bunch of fat, but gained a bunch of muscle, you may be thinking, well, what's the problem with that? Our body needs fat to function. Now, it doesn't need to be 40% fat necessarily, but we do need to a certain amount of body fat to function, to make our gonadal hormones, to make other hormones and neurotransmitters and store energy, so that our body doesn't fear that there's a famine coming. So therefore, atypical anorexia nervosa, you may see, and I've seen this more often maybe with bodybuilders, for example, they've got a kind of a big BMI, they're above that weight that would be expected for their height, and yet they have a lot of those anorexia behaviors going on. Night eating syndrome, reoccurring episodes of night eating as evidenced by eating after awaking from sleep or by excessive food consumption after the evening meal. So that's important. A lot of people think that night eating syndrome, this is the one that the person wakes up at 10 o'clock, 2 in the morning, goes down, just starts cleaning the refrigerator. That's one type. The other type is this person who continues to consume food after the evening meal to a level that's defined by whoever, probably them, as excessive. And there's awareness, and that's key, and recall of the eating. So, it's not during sleepwalking. This is not during a dissociative episode, and the behavior is not better explained by changes in the individual's sleep-wake cycle or by local social norms. Some cultures may do some of their eating at night. Again, I'm thinking about Ramadan, or, think about overnight jobs, graveyard shifts. This person, their primary awake times will be at night when everybody else is sleeping. And yeah, they're eating breakfast, lunch, and dinner when you're sleeping. But we do want to recognize whether something is culturally sanctioned. It's important to remember that we're making the diagnosis in the DSM-5-TR. We do want to look at whether it's causing a person clinically significant distress or impairment. If it's not causing them clinically significant distress, if it's not causing impairment, objective or perceived, then a lot of times it doesn't rise to the level of being diagnosable. If it is explained by another mental health or medical disorder, it may not be diagnosable. And the caveat, for example, is with avoidant restrictive food intake disorder. If the behavior is the avoidance of food is significant enough to become a focus of clinical attention, it can be diagnosed comorbid with the other disorders such as schizophrenia or autism spectrum disorder, but it might just also be a symptom of one of those disorders too. So we really need to see how distressing is the food, is the eating process for them. Now, food addiction, I mentioned, this is not in the DSM-5 TR, okay? However, it is a term that's used a lot, and there are scales. The Yale Food Addiction Scale was actually developed specifically to assess food addiction. With food addiction, the person is consuming more food than intended over a longer period of time. So already sounds a lot more like our substance use disorder chapter than our feeding and eating disorder chapter. So you have that brief episode of eating when they're consuming more food than a typical person would in that situation, or you have somebody who is sometimes what we call grazing. They're just eating all day. There's a craving and a strong urge to eat. And when they don't have access to food, they become irritable and distressed. There's continued consumption despite knowledge of adverse effects. Excessive amount of time is spent thinking about acquiring, consuming, or recovering from eating. And the person may give up important activities in order to eat or recover from eating. So let's look at a couple of those and think about why these might be happening. Consuming more food than intended in any one sitting could be a learned behavior. It could be that the person is nutritionally deficient. What they have to do to access the food, they might end up gorging on it once they finally get it. Consuming food over a longer period of time, a lot of times this is associated with attempts at emotional regulation. For somebody who has ongoing negative affect, we want to look at what is the food consumption doing for them. Craving or a strong urge to eat. Now, this is really common in people with anorexia as well as in people with binge eating disorder and bulimia. In anorexia, a lot of time the body's saying, dude, I need more food, I need energy, I need nutrients. And so these cravings are going to happen. In bulimia, the body might be deficient in certain nutrients or the food may serve to help increase levels of serotonin or dopamine. So it might be sort of self-medication. And when they're not eating, they might be experiencing dysphoria. Continued consumption despite knowledge of adverse effects can happen. And it's important to look at, why is this happening? Why is continuing, or eating less problematic than whatever adverse effects you might be experiencing? And for a lot of people, this is maybe the only strategy that they know how to use that helps them tolerate the distress that they're experiencing. And giving up important activities to eat or recover from eating. Now, this can be because they're so uncomfortable after they eat that they don't want to get up, they don't want to go out with friends, or that they could be craving food that they want to eat and they're embarrassed to eat in front of people. So instead of going out with friends, they stay home. It could also be, and this goes with binge eating in some cases, that the person might feel out of control of their eating. That's the criteria. That's that binge eating. And they're afraid that if they go out and if they eat in front of people, that once they start eating, they won't be able to stop. So we do want to consider those things. Many people with food addiction also qualify for a diagnosis of either binge eating disorder or bulimia. The characteristic difference is the concern with body weight or shape. If that exists, then if they're over concerned with that, then that would be an eating disorder. And the sense of loss of control over eating, that's not specifically identified in food addiction. Now, consuming more food than intended or even eating over a longer period of time, you might argue that, why am I pointing this out? Some people are going to argue that food addiction is a separate diagnosis from any of the other pre-identified eating disorders. And I feel like we're getting down into the weeds here. I feel like we really need to sort of step back, take a look at the person's symptoms. What's causing them distress? What's causing these symptoms? And how can we make it better? Let's get away from those labels as much as we can and start focusing instead on removing a disorder. How can we help this person to live a happier, healthier life as they define it? So, differential diagnoses. Anorexia, the key feature here is an unwillingness to maintain a minimal body weight and energy intake appropriate for that person's age, size, etc., as determined by between them and their physician. Binge eating does not have the compensatory mechanisms that bulimia does and typically involves a far greater amount of food than in anorexia. There can be binges and there can be purges in anorexia, but that undernourishment, underweight is a key feature. In bulimia has both the binging and the purging, and the person typically is about normal weight. The crossover from bulimia to anorexia occurs 10 to 15% of the cases. So some people may have one disorder and then move into the other and then back, and it's typically just not a one-way ticket. There's typically some vacillation back and forth. So we do need to be cognizant of what's going on and where they're at currently and maybe where they've been historically. People with anorexia, because of their severely low body weight, have different physiological risks than people with bulimia. They both have significant severe physiological risks, but we do need to be aware of what is currently pressing in terms of health and safety in any particular phase of that person's situation. And bulimia to binge eating may occur for, quote, another subset. The DSM-5-TR did not identify how many of people with bulimia may go on to drop the compensatory behaviors and just engage in binge eating, but they did say it's another subset. We want to recognize this because binge eating still indicates that the person's struggling with their relationship with food. They're struggling most of the time to cope with something, and so likely they've not reached their highest quality of life. And remember, binge eating is different than just overeating because there's that sense of loss of control during the binge episode. With body dysmorphic disorder, the concern must be about other things other than weight or body shape. It can be about size of their hands, it can be about color of their hair or a freckle or anything else, but the focus of their distress, if it's on body shape or weight, most of the time it's going to fall under one of the other eating disorders. In obsessive compulsive disorder, the obsessions and the compulsions are not related to food, body shape, or weight. In anorexia, obsessing about food or calories is not uncommon because the body is malnourished, so the person's likely going to have cravings. In bulimia, the binge eating disorder, a lot of times the body starts craving the dopamine, serotonin, endorphin rush from the foods that are consumed, which may also promote obsessive thoughts. Now, remember, with obsessive compulsive disorder, you don't have to necessarily have the compulsions. However, in anorexia, there may be very rigid behaviors that a person engages in order to get rid of the obsessions about food. Same thing in bulimia and eating disorder and binge eating disorder. If the obsessions and compulsions are related to food, body shape, or weight, then we look at an eating disorder. If it's related to anything else, we look at obsessive compulsive disorder. If you've got both, then you can have OCD concurrent with one of the eating disorders. In people with major depressive disorder, weight loss is not due to fear of fat. It's not due to an aversion of food or loss of interest in food because of sensory, texture, or aversive consequences, as in avoidant and restrictive food intake disorder. It's due to lack of motivation to get up and get moving and eat. And it's due to that depressive episode. I think there's a lot of reasons why people say they have no appetite when they're depressed. And, I had a client once so depressed that she was just not eating. And we just talked about the thought process of getting up, going to the kitchen, getting 2 slices of bread and some cheese and lunch meat to make a sandwich was just so exhausting. So they just didn't eat at all. And, when we talked about it, I sort of asked, well, do you need a sandwich? Do you need to eat it all together in pieces together? Or can you just eat some bread and later get some cheese and then some turkey and, maybe a tomato if you're feeling frisky? But, this is very different than anorexia. Additionally, so when we look and see significant weight loss, it doesn't necessarily mean that the person has developed anorexia. We want to rule that out. You can have depression comorbid with anorexia, so we do also want to recognize that. If the person gains weight during depression, which is very common, the weight gain may be due to reduced activity when they're not moving around. When people are depressed, they don't have a lot of energy. They might not move around a lot. They might be screwing up their circadian rhythm, so their body's hunger and satiation hormones are out of whack, and they might be making high fat, high sugar choices in order to promote a dopamine surge to feel a little bit better momentarily. They may be grazing throughout the day when they're depressed. They lack energy. They might stay home, so they have access to food 24/7. They may tend to eat more, and there may be occasional binges during depression. And we can diagnose eating disorders concurrent with depression, whether it's binge eating disorder or anorexia or bulimia. But we want to make sure that whether it's a comorbid condition or whether what we're seeing is exclusively due to the depressive episode. We also want to rule out weight loss or gain due to a medical condition. It could be after a particular illness. Some people lose their sense of taste or their smell, and they have no desire to eat. It's not an aversion to food. It's not aversive consequences to food. They just can't taste anything and might be not able to smell very much. So they don't have much of an appetite and they just don't really think about eating. Some people may lose or gain weight as a result of thyroid imbalances or maybe diabetes. Some people may experience weight changes, especially weight loss, if they start developing gastrointestinal problems or diseases of any sort. HIV and AIDS can also lead to alterations in weight that are not eating disorder related. In terms of comorbidity, this list could be a whole lot longer, but we want to look at what's in the DSM 5. And they list anxiety, autism spectrum disorders, ADHD, depression, obsessive compulsive disorders are listed, as is alcohol use disorder. So let's talk about these. Anxiety, especially generalized anxiety and social anxiety, are very common both risk factors as well as comorbid diagnoses with eating disorders. The eating disorder may serve to address some of the fears if they have a fear of rejection from other people, if they have social anxiety, fear of being judged, but we do need to differentiate that from undue influence on weight or shape. They may have a lot of other generalized anxiety. In autism spectrum disorders, as I mentioned, you have sensory integration issues. Same thing with ADHD. You may have sensory integration issues. So certain foods are distasteful or certain smells are overwhelming. So you need to differentiate. This is what we're looking at as far as a symptom of autism or ADHD, or is it a separate disorder? Is it a separate focus of clinical attention? And is it severe enough to be a focus of clinical attention? Then you could have a concurrent diagnosis. Depression, we already talked about as being a rule out, but a lot of people with eating disorders experience depression as a result of nutritional imbalances and their body's inability to maintain the right balance of all of their neurotransmitters. Obsessive compulsive disorder is not uncommon, and alcohol. So, this comorbidity I actually see a lot in my work with substance use disorders. Think back to your college days, or you're kind of in them right now, so I don't know what you guys are up to. But did you ever notice that maybe you just forgot? I put that in quotes because we're not forgetting, we did it on purpose. But when you forgot to eat dinner, the drinks hit a little harder. Well, same goes for any drug that has an oral route of administration, so something that you swallow. Or I'm even hearing that maybe injectable heroin, IV drug use, this can happen too. So people might start developing what looks like an anorexic fixation on not eating, so they get more bang for their buck with substances. Some people lovingly refer to this as drunkorexia, and that's not clinical. Don't use that in your practice, but if you hear it, that's what they're talking about. But, once they get clean and the drugs stop, the fixation on the weight and the calories stays. So, my college roommate, her hack was to donate blood and then go drink. So same, different, different. Not anorexia, but definitely an unhealthy way to manipulate your body. And one that the DSM-5 TR did not mention, but is evaluated in the research, is borderline and avoidant personality disorders. Interesting that those were two things that showed up, but borderline and avoidant personality disorders are far more common among people with eating disorders. They also found that a common thread between personality disorders and eating disorders is emotional dysregulation. So again, that can kind of point to a treatment target for you of let's build some distress tolerance. Risk factors for eating disorders and treatment goals. Risk factors for the development of eating disorders include weight concerns, and this can be socially induced weight concerns, or it can come from family, including a caregiver that has an eating disorder or a caregiver that puts an excessive emphasis on weight or appearance. Low self esteem, social anxiety, childhood generalized anxiety, trauma, and they found that 9 to 20% of people with eating disorders had a diagnosis of PTSD concurrently. So that's a big convergence right there. They found that people with eating disorders tended to have a higher adverse childhood experiences score than those without eating disorders. Remember, adverse childhood experiences are abuse, neglect, abandonment, or a family member in the household that has a mental health or substance use disorder. So they found that people with eating disorders tended to have at least 2 adverse childhood experiences, even if they didn't qualify for a diagnosis of PTSD. They also found that trauma history tended to be greater in people with bulimia. And you might say, well, why not anorexia? They didn't really have good reasoning for that. I would hypothesize that anorexia is more obvious. I mean, people with will see a weight loss. It's observable on the entire body. It's kind of hard to hide that. Whereas bulimia is a little easier to hide. So if they're growing up in a highly conflictual environment, they may be wanting to avoid punishment from their caregivers, for not even eating or what have you, and they may develop a compensatory self-soothing or other behaviors and emotional dysregulation. Even if it doesn't rise to the level of any other disorder, this is a common thread in most eating disorders. So we want to pay attention to this and figure out some treatment goals related to this. Functional consequences, hypothyroid, and most of these are going to be identified by a medical professional. However, most of these also contribute to the potential for the development of symptoms of mood disorders, particularly depression and anxiety. So it's important to make sure that if we're going to help people achieve their highest quality of life, that we're working with a multidisciplinary team that we can address the physiological as well as the psychological issues. So hypothyroid, fatigue, fracture susceptibility, loss of bone mass, erosion of tooth enamel in people with bulimia are all very common. Low primary gonadal hormone levels, and this could be a result of a too low level of body fat. But hypothyroid fatigue and low primary gonadal hormone levels can also be the result of consistently activated HPA axis or stress response system, which you might see in CPTSD, but you might also see in eating disorders because the body is constantly under stress when it's malnourished. And the person might constantly feel a level of emotional distress if they don't feel like they like their body shape and weight. Menstrual, menstrual irregularity will happen as a result of either stress or gonadal hormone imbalances or stress related gonadal hormone imbalances. So that's not that uncommon. Sleep disturbances, particularly insomnia, are common. People are hungry, it's hard to sleep, people are malnourished, they might not get enough serotonin to make the melatonin to get good quality sleep. So insomnia is uncommon. Insomnia is common, sorry. Brachycardia or low heart rate. So that's opposite of tachycardia, high heart rate, as well as life-threatening arrhythmias and sudden cardiac arrest are also common in both anorexia and bulimia. It's important to recognize that the compensatory behaviors often throw people's electrolytes way out of whack, which can significantly impact their risk of heart failure. Cardiac myopathy is also commonly seen in anorexia and bulimia, and that's a disease of the heart where it has difficulty pumping like it's supposed to. Hypotension, low blood pressure. This can be seen a lot of times due to excessive hydration and insufficient eating, and a lot of people with eating disorders, as well as compensatory behaviors and electrolyte disturbances. So, all of those are obviously outside of our scope as behavioral health professionals. But the important things is to have them evaluated in order to prevent the development of associated mood disorders and other health issues in order to maximize the treatment potential. Suicide risk in anorexia nervosa is 18 times greater than their matched controls, according to the 5TR. Additionally, 25 to 30% of people with bulimia or binge eating disorder have had suicidal ideation, and a similar proportion, 25 to 30%, have attempted suicide, according to the DSM 5. Traditionally, the crude mortality rate, which is the ratio of the number of deaths during a year to the average population in that year, for bulimia nervosa was about 2% per decade. So, about 2% of people in a particular population per decade may die from bulimia, and that's a lot. That's 2 out of every 100. So, assessment can begin with a thorough clinical history and maybe augmented with an eating disorder examination interview. The actual prevalence of anorexia, bulimia, and binge eating disorder is still highly speculative. If somebody presents with a food related distress, we need to take it seriously. We know suicidal ideation in people with eating disorders is very high. Therefore, it's not something to be minimized or taken lackadaisically. Nutritional disturbances and body image disturbances may have a significant impact on the course of the disorder and the development of comorbid physical and psychological issues. And in Pittsburgh, there are two really great referral sources for specialized eating disorder treatment. It's the Emily program and the Renfrew Center. And I know at least the Renfrew Center offers free trainings. So if you're interested in learning more, you can sign up on their website for one of their trainings about treatment, but they're just, a really friendly bunch of people. I think their office is on Craig Street in Oakland. So, you can also just stop by and talk to them. They're really wonderful. And they have, both of them have multiple sites throughout the country and inpatient facilities too for treatment. So it's not just outpatient, it's linked inpatient, and they would do an assessment for your client. And they have doctors on site to run all those tests and look at the BMI and really assess thoroughly. So both really great referrals. And today we didn't cover pica or rumination disorder, but if you have any questions about this section, feel free to email me, get in touch, sign up for office hours. I would just love to see you and talk with you. Thank you.